Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Shara Bialo. She's a pediatric endocrinologist. Today's Kevin MD article is Why Type 1 Diabetes Screening Should Be Part of Back to School. Shara, welcome back to the show.
Thank you. Thanks for having me back.
All right, so tell us what your latest article is about.
Yeah, so I'm a senior medical director of T1D immunology at Sanofi, and I'm a board certified pediatric endocrinologist. I live with type 1. So this topic really sort of sits at the intersection of my personal and professional life. And really, this article is about, leveraging opportunities to talk about the risk of type 1 diabetes.
All right, so you point out in your article that 90% of new diagnoses for type 1 diabetes have no family history. So tell us more about the context of what that statistic means.
Yeah. So that's really a myth. I think like a chance for a myth buster is that most people think that type 1 diabetes only runs in families, and that's really not true. I mean, it's true that if there is a family history of type 1, that confers up to 15 times increased risk for family members that aren't yet affected. But the truth is that of the 64,000 new onset cases that we see a year, 90% of them it feels like it's coming out of left field for them. They have absolutely no idea where this came from. They may have a family history of autoimmunity, and that's sort of an important clue when we see people clinically to sort of surface the topic of type 1 diabetes risk, but the vast majority have no idea, where it came from.
So tell us a common scenario where someone would first find out they had type 1 diabetes.
Yeah, so by and far, people are presenting clinically, which means that they're developing signs and symptoms of hyperglycemia, frequent urination, frequent thirst, maybe some weight loss. Upwards of 60% of kids and somewhere around 20 to 30% of adults are presenting in diabetic ketoacidosis, which is when the body absolutely has no insulin left in order to utilize glucose as fuel and starts burning fat for energy and creating ketones as a byproduct. And that's throwing off acid base balance and throwing people into diabetic ketoacidosis, which is really, a crisis scenario. So that's really how people are presenting. But the truth is that type 1 diabetes, when we think about it clinically, that's actually the third stage of the development of type 1. And it's actually developing over multiple stages previous to that are asymptomatic and therefore silent, but can be detected with autoantibody testing through blood testing.
And around what age do people develop clinical symptoms for the first time for type 1 diabetes?
Yeah, so the highest incidence is around 10 to 14 years of age, but
Okay.
really it can happen at any age. And if you look at the curves, 10 to 14 is where it peaks and then it kind of comes down and it starts to rise again after age 40 to 50 or so. So we're seeing older adults being diagnosed with type 1. I think it's very common for them to be misdiagnosed as type 2, given type 2 is a lot more common in adulthood. But there are some clues to kind of consider autoantibody testing for the purpose of differentiating type 1 from type 2.
And in general, how is type 1 diabetes screened for?
So it's not happening in a widespread way right now. It's becoming a hotter topic, and it's definitely present in guidelines that endocrinologists follow, like the American Diabetes Association or ISPAD, which is the International Society for Pediatric and Adolescent Diabetes. Actually, just last month at EASD, which is the European Association for Study of Diabetes, their big conference, Breakthrough T1D presented a consensus guidance on screening, like who should be screened and how often, and really made a case for population screening, which, I think we'll probably have to work toward if we're going to identify the vast majority of people who present with type 1. But it hasn't yet found, screening as a recommendation hasn't yet found its way to, United States Preventative Task Force Services or American Academy of
Mhm.
Pediatrics guidelines, but it's definitely being discussed more frequently.
In the article, you talk about your own personal story about screening your children for type 1 diabetes, right?
Yeah.
Tell us more about that.
Yeah. I am honest, I'm an open book, and I, as a parent, was very hesitant to screen my own children. We hear families talk about really not wanting to open that sort of Pandora's box. It's really I talk about it in terms of like Schrodinger's cat actually, where
Mhm.
if you open it, you know for sure like what's there and it may be this whole sort of self-fulfilling prophecy. But I felt that same fear and guilt that my family's described in clinic, which is worry that my children would face the same challenges that I do living with type 1 diabetes. And even though it's not rational, sort of this associated guilt over the fact that it would be coming from me if they have a risk of developing type 1. And ultimately, I got past that with the thinking that screening, it isn't so much about predicting doom or
Hmm.
assigning
Hmm.
blame, right? It's about giving our family time to prepare and information and options for how to manage a diagnosis earlier without having to deal with it in a crisis situation. So ultimately, through some hand holding with my husband and my family, I did get my kids screened, and luckily, knock on wood, they were negative, and I think I underestimated the relief in not detecting
Hmm.
autoantibodies, and I don't feel like we lend enough attention to that. And I'll continue to get them screened. Screening is not a one and done.
Hmm.
Autoimmunity can develop over time. And so I feel much more confident moving forward that if heaven forbid we were to detect autoantibodies, and that would convey a 100, almost 100% lifetime risk of developing clinical type 1, that we would be able to manage it on our own terms, right? On our own
Yeah.
timeline, and take advantage of research or take advantage of earlier monitoring to avoid things like DKA and all the advantages that come with just knowing earlier.
So just give us a basic primer on type 1 diabetes. It's, of course, more of an autoimmune phenomenon. So just give us the different ways that we could screen. You mentioned autoantibody screening. So tell us exactly
Yep.
more about that test.
Yep. So a lot of people think type 1 and they think of blood glucose, which is not wrong. But by the time your blood glucose is abnormal, there's already sort of been damage, right, on a baseline level. And we have the opportunity to catch it even earlier by not relying on blood glucose changes. We can catch it before blood glucose changes even come to pass by measuring autoantibodies. So type 1 diabetes, as you mentioned, is an autoimmune condition. It's where the immune system goes a little haywire for reasons we don't quite understand yet, and starts attacking the beta cells in the pancreas, which are responsible for insulin production. And the signal for that is positive diabetes autoantibodies. Now, the autoantibodies themselves are not the problem. It's sort of like a check engine light. Like the light
Hmm.
is not the problem, it just signals an issue underneath. But the autoantibodies, they're available to measure through commercial assays like through Quest or LabCorp. You can also go through large scale research studies like TrialNet or the ASK program out of the Barbara Davis Center in Colorado, which stands for Autoimmunity Screening in Kids, which are able to, you can mail order a test to your home in order to test for these autoantibody levels. So there's a variety of different ways to check for autoantibodies, but the main idea being that if 2 of the 4 available autoantibodies are positive,
Hmm.
that is what I referred to previously, that conveys an almost 100% lifetime risk of developing clinical type 1, and really makes the diagnosis of type 1 diabetes regardless of what the blood sugar is. So if your blood sugar is normal, but you have 2 autoantibodies, that's the first stage of type 1. And then as the blood sugars become mildly abnormal or dysglycemic, that's stage 2. And then stage 3 is when you become grossly hyperglycemic. And that's the type 1 that we're all sort of familiar with. But we have this sort of latency period before the development of those clinical signs and symptoms where we can act and potentially, change someone's course with type 1
Hmm.
in a very positive way.
Now, are you advocating for screening the general population or more targeted screening? Are there any risk factors that could portend a potential diagnosis of type 1?
Yeah, I think if we turn to the last page of the book, right, then hopefully we'll get to population screening, because with 90% not having that family history, I think that's the only way that we're going to help the most, like the highest number of people. But we're not doing anything right now, right? So I think
Hmm.
we do need to start somewhere, and it makes sense to start with the lowest hanging fruit. So we know that, the lowest hanging fruit are going to be people with first or second degree relatives with type 1 diabetes. And then the other branches that are a little bit lower on that tree are a personal history of autoimmune disease, especially thyroid disease like Hashimoto's or Graves' or celiac disease.
Hmm.
If there's a personal history of those, or even if that runs in the family, that's gonna lend itself to a risk of developing type 1 that really comes close to having a second degree relative with type
Yeah.
1. So the risk is pretty significant, and those data are you know only now being published, and we're learning more about what it means to have another autoimmune disease and then develop type 1 later. So I think that's where to start. And endocrinologists are are taking this on with more and more gusto, but they're sort of limited to the patients that are already in their practice for other reasons, right? Autoimmune thyroid disease or type 1, and then they're counseling them to screen their family members. And I think ultimately we'll have to land at primary care and pediatrics to start to spread this message as a part of preventative care along with, well child checks or end of year visits.
So you mentioned also the role of schools, right? And that you mentioned that there are some state laws that encourage type
Mhm.
1 diabetes education in schools. So tell us about those states and those initiatives.
Yeah, so this actually started in California thanks to, a family who was motivated to advocate after unfortunately their child developed a terrible outcome from undiagnosed clinical type 1 diabetes, having fallen into decay and not survived. And so it started as a measure to sort of see the signs of clinical type 1, the drinking, the
Mhm.
thirst, and to not chalk it up to other reasons like flu and other excuses that people make for those symptoms. And so that was already sort of in place in school systems to sort of see the signs of type 1 within California. But now that the word is getting out about the benefits of early detection of type 1 even before symptoms arise, there are efforts to sort of piggyback right on those existing bills and to say, yes, learn the signs, but also, did you know if you have this increased risk in the family, you could catch it before signs even roll out or before DKA could even occur. And so that spread, and it's making its way through legislation on a state-based method, and it sort of depends state to state what it
Hmm.
looks like, but the sort of common thread in all of it is that the Department of Education could take this information and decide to post it on a website or disseminate it at the beginning of school. There are some states where school nurses are taking this on robustly and providing sort of proactive education, but it will look different state to state. But I think, it's hard. I think public health messaging is hard, and it takes all hands on deck, and schools are a great place to start.
And what's the main message you have for parents who may be listening to you now? Is this something that they should ask their pediatrician about? If their pediatrician doesn't screen for type 1 diabetes, how should they approach their healthcare professional?
Yeah, I think partnering with the primary care team, the pediatricians, is a great idea. If they're not familiar, it gives them a chance to learn about it. And chances are they are familiar because of, the rollout of education that's been occurring over the last few years related to this topic. Sometimes people are met with confusion or misunderstanding, and they'll get, again, a lab for an A1C, if
Hmm.
anything. And that's not really going to detect diabetes in the earliest stages. And so self-advocacy does become key, especially if you're someone that, your family is highly impacted by autoimmunity or by type 1 in particular. It does sometimes require some self-advocacy. But that's where, there are some people taking action into their own hands and
Hmm.
going toward these research studies where they can order kits themselves to the home. There's actually, not only through research, but there's commercial options for ordering testing independently for diabetes autoantibodies. So, just depend. I think optionality is what we need, right? There's lots of choices for people who are interested in understanding their risk and acting early.
So, what do you see in the pipeline going forward in the foreseeable future when it comes to screening type 1 diabetes? Are you seeing any potential initiatives when it comes to changes in guidelines? And what's coming down the pipeline?
Yeah, I think so. I think it's definitely a hot topic right now. I've been attending, pediatric endocrine conferences for over a decade. And in the last 3 years, it's definitely become a common topic in sessions and in symposia. So I do think it's gaining speed and gaining momentum. The professional societies that pertain to diabetes are on board. And I think that invariably and sort of inevitably will trickle into primary care and sort of more general preventative care. And so there have been conversations, with the larger institutions and societies. I know that patient advocacy groups like Breakthrough T1D have escalated this to the U.S. Preventative Task Force Services, and there are advocates in the field who are appealing to the American Academy of Pediatrics. And so hopefully we'll hear, some positive outcomes from this. So it's an exciting time, and it's definitely something to be aware of and to take seriously.
We're talking to Shara Bialo. She's a pediatric endocrinologist. Today's Kevin MD article is Why Type 1 Diabetes Screening Should Be Part of Back to School. Shara, let's end with some take home messages that you want to leave with the Kevin MD audience.
Yeah, so I think that really my message is simple, is really just to consider making type 1 screening a normal part of preventative care. We're at the end of the year now. End of year appointments are sometimes one of the few times that clinicians get to see their patients or families, and that moment can really change everything. So a quick conversation could prevent a life-threatening hospitalization 6 months from now and give parents and families time to prepare and monitor. So really it just comes down to educate, advocate, empower, and that understanding, the responsibility and power we have as clinicians to help families understand their risk and take action early.
Shara, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Thank you. Appreciate the platform.